fungal keratitis. The inflammation which is caused by the inflammation of the cornea caused by the fungi is called fungal keratitis. It is a potentially a blinding condition, okay? It is more dangerous as the bacterial corneal ulcer is more progressive, rapidly progressive. But it is more dangerous than bacterial type, okay? We have two types of fungi which can cause the inflammation of cornea. There are filamentous fungi and candidal fungi. So filamentous fungi, these are for example the fungi Aspergillus, Curvularia, Fusarium. These are the fungi. These fungi are mostly present in the tropical environment, warm and moist environment. They reproduce by hyphae formation, okay? So there will be the formation of hyphae like this, okay? This is one hyphae, this is second hyphae, this is third hyphae, okay? So the filamentous fungi, they are in tropical environment. They reproduce by the formation of new hyphae, okay? And when there is the filamentous fungal keratitis, what will be the clinical features? The clinical features are, as I told you before, that the pain, photophobia, blood vision, lacrimation, redness, foreign body sensation and discharge will be present in all cases of corneal disease, okay? But the specific feature for the filamentous fungal keratitis are that the corneal ulcer which is grayish, okay, what will happen? The ulcer, the edges of the ulcer, it will be feathery edges, okay? Delicate feathery edges will be present, okay? These will be a delicate and feathery edges, okay? Delicate and feathery edges. So corneal ulcer with delicate and feathery edges. If the filamentous keratitis, it is superficial, then it can also cause a visible elevations on the cornea, okay? So the hyphae, due to the hyphae formation, it can form visible elevation of hyphae on the cornea. The deep lesion can cause hypopyon ulcer, okay? And satellite lesion may be present. What are the satellite lesion? The satellite lesion are the multiple lesion, okay? The multiple P3 lesion may be present, okay? So the multiple P3 lesions, these are called satellite or multifocal lesions. These may be present. So these are the clinical features with filamentous fungal keratitis. Now candidal keratitis, candida, for example, yeast. These are the fungi, these are unicellular fungi. Mostly they are present in temperate environment and they are mostly reproduced by budding, okay? So they will form, for example, if this is the fungi, it will form a bud like this and it will reproduce. So it is mostly reproducing by budding. This type of candidal keratitis causes the dense suppuration. It causes the dense suppuration in the cornea. It will look like that it is caused by gram-positive bacteria, okay? So it will cause a dense lesion and dense suppuration in the cornea, which will look like that it is caused by gram-positive bacteria, okay? How can we diagnose the condition? The condition can be diagnosed as like the bacterial through gram staining, GEMSA staining, PCR, etc. But we have some specific types of diagnosis procedures. As the potassium hydroxide preparation can be done, which will tell us whether it is fungi or not. Interior chamber tape. If we take the fluid from the interior chamber, okay, through injection, if we take the fluid, then we can also diagnose the condition, okay? And if through all this investigation, if it is not indicated what is the problem, then we can also do biopsy, okay? Biopsy will tell us that whether it is bacterial, fungal or viral. Or we can do a recent technology has been arrived which is called in vivo confocal microscopy. In vivo confocal microscopy is a recent non-invasive technique in which we can directly see the fungi in the cornea. Okay, so these are some specific diagnostic tests for the fungal keratitis. Now the treatment. How can we treat the condition? The condition can be treated by antifungal drugs. Okay, so antifungal, for example, natamycin. Natamycin is mostly effective against the filamentous type. Okay, we can also use fluconazole. Okay, we can use amphotericin B. Amphotericin B is a broad spectrum antifungal drug. It is effective against almost all kind of fungi, but it has some serious side effects. Uriconazole can be used. Uriconazole has a powerful penetration power through the cornea and its trauma. Okay, and we can also do systemic antifungal therapy in the form of fluconazole and ketoconazole. Okay, remember if the lesion is deep, if this is the cornea, corneal layers, and if the lesion is deep in nerve, the systemic therapy is reaching, now the topical therapy is reaching. What will we do? We will give the patient uriconazole, intrastromal uriconazole should be given. As the uriconazole, I told you, has a strong penetration power through the cornea and stroma. So if there is the resistance to the topical therapy or systemic therapy, then intrastromal uriconazole should be given. Okay, so this is the treatment for the fungal keratitis. So this is about, the first one was bacterial corneal ulcer, the second one was fungal keratitis. Okay, now if we diagnose the condition, if we treat the condition, it is all best. But if the ulcer is not healing, what will we do? If now still the ulcer is not healing, whether it is bacterial or it is fungal, but it is not healing, then what will we do? So what are the treatment options for the non-healing corneal ulcers? The treatment options are multiple. Okay, I'm sorry I don't have this right now, but I will raise it over this tissue. Okay, so the treatment options for the non-healing corneal ulcer, these are multiple. We can use bandage contact lenses. Okay, so the bandage contact lenses can be used. Okay, the pressure bandage contact lenses can be used. We can use conjunctival flap transplantation. So we will take the conjunctiva and we will cover this bare area by the conjunctival flap. Okay, so conjunctival flap transplantation can be done. Conjunctival flap. We can also transplant this bare area. We can also cover this bare area with amniotic membrane. We know that amniotic membrane has growth factors and has stem cells. So it will regenerate this defective epithelium. Okay, we can do amniotic membrane transplantation. We can also get the patient, we can also get such as the growth factors. The growth factors can be taken from the serum, or it can be taken from the spermatic cord. Sorry, from the umbilical cord. Okay, so from the umbilical cord we can extract the growth factors and we can get the growth factors. So it will enhance its the healing of this defective epithelium. We can do growth factors. We can also do a surgical procedure which is called tarsorrhapy. What is happening in tarsorrhapy? We will close this, we will give sutures on the lid margins, on the lateral side as well as on the medial side, and the eye will be closed. Okay, like this. We will give the sutures in this side as well as in this side, and this interpalpebral diameter will be reduced. This is called, okay, this is called tarsorrhapy. So tarsorrhapy can be done. Tarsorrhapy can be done. So if the corneal ulcer is not healing, then these are the multiple treatment options. The last remedy for the non-healing corneal ulcer, what is that? It is the transplantation of the whole cornea or the layer of the cornea, which is called keratoplasty. So we will take the cornea from the donor and we will entirely transplant the cornea. This is called therapeutic keratoplasty. Okay? So therapeutic keratoplasty can be done, and which the whole cornea is transplanted by the donor's cornea. Okay? This is the last remedy with us if these all procedure fails to heal the cornea. Okay? So the last procedure is therapeutic keratoplasty. I also have prepared notes. I will give the link in the description. You can go through the notes and can learn more. Thanks for watching the video.